everyone. Welcome to Digital Health Talks. This is Megan Antonelli, and today we're continuing our Food is Medicine and Female Founder series. This one is a 2-for-1 and is a conversation that hits close to home for millions of families. On January 1st, 2026, Delaware will make history as the first state to require insurance for early allergen introduction, a policy shift that could prevent countless food allergies and save healthcare systems millions of dollars. My guest today is Meenal Lele, founder and CEO of Lil Mixins and Hanimune Therapeutics. Meenal is an engineer with multiple patents, published clinical studies, and over a dozen profitable medical products. She's also the author of The Baby and the Biome, and most importantly, a food allergy parent whose personal experience drove her to build evidence-based solutions for 33 million Americans living with food allergies. Lil Mixins is the only insurance-covered brand for food allergy prevention, and Meenal's work is changing how parents and physicians approach allergen introduction. This is a story about maternal insight meeting scientific rigor and proving that prevention works. Meenal, how are you? Welcome to Digital Health Talks.
Thank you so much for having me. I'm doing great today. Thanks.
Yeah, I love this story. I mean, for so many reasons. Obviously, as a mom, had so many, friends and kids in our sort of circle with allergies, and it's just knowing that when you have kids, all that focus on them and how to help them is so important. And I just love your story of how you founded Lil Mixins. Tell us how it came to be.
Yeah, so the story is well trodden, but my older son ended up developing a whole bunch of food allergies, and kind of looking back, he is what one would consider a low risk kid. No family history, normal birth, healthy. I guess eczema, but pretty mild, honestly. No real risk factors, and but the one thing we didn't do was train his immune system that these were foods he was going to be seeing when he got older, and so he ended up developing a bunch of food allergies. And then it's upsetting. I would say like the egg allergy, is kind of the most frustrating because it's just in everything. And in all the things like kids like birthday cake. And anyway, so when my younger son was born, we really wanted to, we found out a week after his first ER visit that food allergies turns out is a preventable disease. And so we're upset. And then when my younger son was little, we did early allergen introduction with my younger son who doesn't have any food allergies, but it was just really difficult. And, we can get into this, just how stacked the odds are against a parent trying to prevent allergies in their kid. And I don't think I fully understood that stack when I thought, hey, what we need to do is make this, relatively inexpensive for parents and super easy to do, because people don't do things that are difficult and expensive, right? Especially prevention. So that's kind of how it started. And I really wanted as many other kids to not go through what my kid was going through if it was avoidable.
Yeah. Well, and it is, it's one of those things. I mean, I always think so much about how, as you have kids through the decades, the practices and the recommendations change, right? I mean, my mom my mom actually had 3 kids in 3 different decades, right? 74, 84, and 96. So the differences of what she was told to do changed dramatically. And of course, then I started having kids in 2004, and so the changes were happening. And so seeing that, and certainly allergies have been something that the recommendations have changed. So tell me a little bit about that. I mean, because I think I'm actually, when I had my kids, we just couldn't eat anything, right? You didn't give them the stuff. So I think the recommendations have changed over the years. So tell me a little bit about that, and then we can get into some of the other stuff around your great.
Yes. So the story is really that, like you said, I'm a kid of the 80s, and there weren't really food allergies back then. I mean, they obviously have always existed. They were just much more rare. In the 90s, the rates started spiking, and so the pediatricians didn't really know what to do. And so in I think 2000, they started making this recommendation that was avoid all these foods in infancy. And a great way to not have an allergic reaction is to just avoid the foods, right? It just so turns out that also avoiding the foods in infancy will cause the allergy. So, but in 2008, they kind of walked back from that a little bit and said, like, actually, we don't have any data. We never had any data when we said that. We just sort of were like throwing darts in the dark. And and then the LEAP study published, and that was the first big randomized controlled trial that they actually were like, well, let's just ask the question, like, what happens? And they showed that in children, specifically in family, and this is really important for families that are eating these foods. So if you eat peanut in your household and in your family, the child, the infant, to be clear, being fed those peanut, in this case, between the ages of really like 4 months and 12 months, cut the risk that baby would develop a peanut allergy by well over 80%. So that's a really massive effect, right? And then they show the same thing for egg. And so now then they, in 2020, the recommendation swung to say, actually actively introduce, peanut and at least peanut containing products and well-cooked egg containing products into the infant diet no later than 6 months, no earlier than 4 months, and keep it in the diet. And then they make more of a passive recommendation around the rest of the foods. It's just because it's harder to do the randomized controlled trial. So they don't have, it's more rare. So they don't have a study that shows and proves that hazelnut, for example, risk will be reduced. And so they say there's no reason to avoid hazelnut, for example, but they don't have the data to say, like, definitely make sure the kid's eating hazelnut.
Right.
But in theory, anything you're eating in your house, that's what the kids should be eating too.
Right. Except the subsequent addiction to possibly Nutella that could then be problematic.
Yeah.
But yeah, no, it's interesting. I mean, my first son was born in 2004 and then 2011. So just in the same household, the recommendations had changed for sure. Mm-hmm. And you have an incredible background, coming not from a clinical side, but as an engineer. How did that, shape how you approached this, problem solving in your household?
Yeah, it's a great question, actually, and I talk a lot about this sort of idea of there's a known phenomenon of a 17-year bench to bedside lag, meaning that, like, after people definitively prove something, it takes 17 to 20 years for it to actually be implemented in practice. And that's a lot of people born, right, in 20 years, and that's a lot of time, and which maybe was cool if you're getting your news monthly. But now that we get our, news and everything else updated every few seconds, 20 years is like eons, right? But anyway, yes. Yeah, so I'm not a clinician and a doctor. And so nothing, we're not focused on proving that this stuff works or even inventing the idea that it works, if you will, right? That was all done. The question was, like, how does somebody actually do this? And I think that's interestingly a classic case of where science can often fall down. It just sort of says, like, this is what we should do. And we can talk about it. This is true of anything, right? Because we might have recommendations, and we're seeing this a lot with food, right? We have these recommendations, well, people should eat less sugar. And that's fine. And it's true. It's just a question of, like, if all the food in the child's diet at their lunch is full of sugar, what are they supposed to do, right? So we can't just say eat less sugar. We have to actually get it out of the lunch, if you will, right? Or out of and so very similarly, we focus on the how, which is what were the barriers? Well, none of these foods are safe for an infant. You can't give a baby a hazelnut or even a peanut. You can't even give them peanut butter. They'll choke on it at 4 months, right? So how do you do this in a pre-prepared way? And then secondly, it doesn't work if you give them random trace amounts. So if you were to sort of, like, dip your pinky in peanut butter and let your baby suck on it, that is not an adequate quantity to train their immune system. They need to be eating 2 grams of the protein. I mean, do you happen to know off the top of your head how much peanut butter is 2 grams of protein? Like, no, nobody does, right? So how do you take that work and that thinking out? Because remember, like, if this parent has a 4-month-old, their, like, high priority here is, like, when is nap time? Which of the 17 meals a day are we on? There's just so much else going on between are they turning their heads right and they're doing this and that and all the other stuff. So we got to make it really, really easy.
Yeah, no. And right. And when I just remember being, a new mom and everything is overwhelming and there's so much, there are so many sort of rules and recommendations, and everybody from your mother-in-law to your mother to what to expect when you're expecting has recommendations on what to do, and then they change. I mean, back to your point around the 17 years from bench to sort of practice, and I think we're seeing that now. I mean, we're seeing a lot of things coming out on the internet that work, and people having these sort of anecdotal sort of real-time recommendations and studies, and you see that. I mean, plus certainly sort of the growth of GLP-1s and people's medication and all of that, and that being so rapid, how people have taken it, that in fact their anecdotal evidence is the body of work and body of science that then then the researchers are going back to. And I think with allergy it's much the same way, because it's one of those things where there isn't the financial backing to drive the research, because it's about something you're not supposed to eat. There's not something you can necessarily sell, except in your case, to prevent them, and so that sort of work and research doesn't get done, which speaks to kind of the broader challenges within the system of healthcare in the country. And so I want to talk a little bit about, what's going on in Delaware. Tell us a little bit about this insurance mandate. I think, it's important for everyone to understand what that means and why it's even a thing. Because it's like, why wouldn't it be covered?
Great question, right? You would think like, oh my gosh, how awesome. Like the doctors proved that something so simple works. Like we would be handing it out in leaving, baskets as people leave the hospital or whatever. But no, that's not how it works. It turns out that basically, insurance will cover things that are drugs and things that are treatments in the, medical devices or surgeries or things like that. When there are interventions that are actually so low cost that they're actually just food, insurance refuses to cover them. And but we have examples from the past, right? So we take the example of folic acid. It was proven that this could prevent all sorts of, neural tube defects in pregnancy. And so eventually legislators stepped in and said, insurance has to cover this, because human beings, first of all, most parents don't have that much money, right? So even something that costs, you might think, this sort of prevention at $30 or $40 is not very much, but it's a lot to some families. And it's specifically a lot about a problem they don't have today, right? So I think, and that's really one of the things that gets confusing for people, because most of us are motivated to spend money once we have a problem. But honestly, if you ask, most of us would love to just not have had the problem in the first place, right? So yes, am I motivated to be on a GLP-1 or, to get the ACL surgery or something after it's torn? Yeah, sure, definitely. But maybe I just didn't want to tear my ACL at all, right? And if you could have given me, and I'm not saying this is a real thing, I just mean if every kid in playing soccer gets the right warm-ups so that they don't tear their ACL, we would all prefer that, right? But that's not an industry. And so this is the same thing. Like the legislators in Delaware recognized, and it was, I really want to give props to Kim Williams here, who is a representative in Delaware. And she was the first to really see but this just saves the state so much money. And I hate to make it just about the money, because I really do want to, Americans today, so many of us are suffering from chronic diseases, so this shouldn't be that hard for people to empathize with. But chronic diseases are awful, right? You just never get to let up. And there's no real way to define the value of just not being miserable all the time, right? But it is like, if you have food allergies, you're constantly cycling. Like, what am I going to eat? How am I going to eat it? Right. So I'm thinking about, I was just looking at a flight, for example, and the flight had a layover. And so most people are thinking, oh, that's 3 extra hours or whatever. But no, I'm cycling. If I'm taking my son, how will we have enough food to last that layover? What if it's a different meal? Will they let us pack multiple different kinds of meals? Can I afford a layover? Even if it's cheaper, I might pay twice the money for a direct flight just to avoid an extra meal. Yeah. Right? And that is a lot of thinking to do months before a trip. But that's what your life is like about everything. Can I go to this networking event? And so, but that's not how we factor in costs. And Kim Williams really saw that, and she was like, no, the trauma that these people feel and then the difficulty they'll have navigating life, that's what she wanted to prevent, right? And so she's a force of nature, but she really took the time to help all of her colleagues see the benefit. And once it was interesting, all the doctor societies sent in their letters of support and things like this, but once we got down, but most things in just don't move. They never move. But she made it move, right? She insisted that it come up for a vote. And then once it was up for a vote, all these legislators stepped in and said, hey, my constituents have these allergies. I have an allergy. If we can do this, this would be great. But, right now we're stuck in a couple states in Pennsylvania and New York where it just won't come up for a vote. And so I just want to give Kim Williams, Representative Williams, the credit she deserves, right? It was that she was a force of nature. She is a force of nature.
Yeah. Well, it is, I think it's incredible that you were able to kind of work with Kim and make this change happen. But I think, the fact that it needs to happen to make this a thing is, what is it's sort of shocking. So in terms of Lil Mixins and what it is, tell our audience a little bit about how it works and kind of what the process is and how it helps.
Sure. It's the opposite of rocket science. It's literally just defatted, dehydrated food. That's it. There's nothing more complicated than that. So if babies are supposed to be eating well-cooked eggs, which means a hard-boiled egg, but those things are not shelf-stable, right? So then they become expensive. So the magic is taking that and dehydrating it so you can put dozens of eggs worth into a single unit, and that can last someone multiple months to do it. But then once it's in a powder form, a dehydrated powder form, it's very easy to measure specific doses, right? Then you can say, well, this scoop size is equal to a serving. This is not complex stuff, but it's just, instead of saying a third of an egg or something, but what size egg? Grade A, grade B, whatever. It's a scoop. And same with peanut butter, right? We just take the fat and the water out so it's shelf stable. In both cases, it maintains all the nutrients, but just now it can't choke a baby, and it's easy to dose or make servings.
Right. And so it's added to the baby food or to at the right age, and you give that kind of dosing appropriate. And Correct. And in this, obviously, I'm sure parents who are sort of on top of it, and but as you said. It costs money, it's expensive. So we want to get insurance coverage for it so that it is sort of part of that, almost like part of the vaccine curriculum, schedule, right?
Correct. It also just takes time. It takes 30 minutes to boil an egg, let it cool down, puree it for the baby. And that's 30 minutes that when you're very tired with a 4 to 6 month old, you don't have, right? And that labor is also, this is another thing, right? Like the mom's labor is never counted. But if you factor in the labor of preparing these foods, it's so much cheaper to just make it ahead of time.
Right. And then, in going back to kind of the insurance coverage, and as, we've talked a lot about food as medicine, and I think it sort of came into our vernacular. I mean, obviously there's Michael Pollan and there's all these, sort of movements, but as it started, I don't think it really kind of came into healthcare administrator politics, sort of the policy piece of this, less about 5-10 years ago. And now, it's gaining momentum. You're seeing events around it. You're certainly seeing some people willing to talk about it. However, and we've got examples of health systems that are, funding their own farms and trying to feed real food to patients and getting the benefits of that. But who's paying for it? In general, it's the health system, or, there are a few areas where you're seeing some pockets of Medicaid paying for some programs. We've had the folks from Eat Real on the show in terms of schools and school lunches and as a place where that, is able to get into it. But, this in terms of, insurance coverage and, to some degree, what's broken about our system is that we don't pay for prevention. Right. And then we say, and when we talk about the importance of prevention, we say, who's supposed to pay for it, right? And the ones that we come to are, the employers or the insurers have the most financial interest in paying for prevention. So, you've done a lot of work in Delaware. Now we're coming to sort of in Pennsylvania and New York. What are some of the barriers? Why isn't this like, yeah, obviously we're going to cover this. It's so simple. It's not an expensive intervention. It's certainly less expensive than any kind of anaphylactic episode that a child might have because of an allergy reaction. So what's the, what is the, what are the barriers here?
If I may step back for a second, I want to bring up the point you made about, Michael Pollan and everything else. And I think this has gotten kind of conflated a little bit, because there's sort of food is medicine and food as medicine, and they get used interchangeably, and they're a little bit different. And I know I'm splitting hairs, but I just want to talk about this, because I almost feel like there is diet as medicine. And that's, I think, what most people mean when they say food as medicine. They're like, what if we just ate better, right? If we were overall healthier, and that would obviously make us all better off, right? And I'm totally pro that, obviously. And then I think in this particular case, this is a specific example of food is medicine. Like the food is literally the drug. And if you think of medicine as drugs, right? And food, early allergen introduction is as direct an intervention as like giving sailors vitamin C so they don't get scurvy, right? It is that linear of a correlation or mechanism of action. And so, or folic acid in pregnancy, right? Like where it's just so happens that the drug itself happens to also be a food. And I'm just differentiating those two situations, because you would think that it would be hard for a system to get around the idea that, oh, what am I going to do? Pay for everyone's Whole Foods bill, right? That diet as medicine should be harder to wrap your head around than food is medicine, right? Where this, like, I'm just preventing scurvy. Like, that should be really straightforward. And it isn't. And it's, honestly, the only opposition we have to the bills in Pennsylvania and New York are the insurers themselves. And they have come out and said that they will fight a mandate, but they won't do it without a mandate. That's it. They said it will cost 12 cents a person, that they know that that's the cost, not the savings, right? So long term, it will save them a ton of money. They admitted that was their own analysis. It's 12 cents a person. And they said they will not do it. Everybody, nobody likes food allergy. Nobody is better off in a world with more food allergy, right? Like teachers hate it, the restaurants hate it, tourism hates it, employers hate it. It's increasing, like we can't have a lunch in our office anymore or it's really difficult to do or go on a field trip or whatever, right? Everyone's worse off. You know who else hates it? The egg producers of Pennsylvania, right? Because who's eating their eggs if everyone has an egg allergy? You know where all the peanuts and eggs are grown? In the United States. And so we're hurting our own agriculture basis, right? But so all of these people are worse off. Right. But the insurers are fighting it and they're winning. And that to me, and when they were asked, why are they fighting it? They said, well, we're forced to cover folic acid and not everyone uses it. This is in writing. And you're like, well, how is that a problem?
Right.
Mystery.
Right. No, it doesn't make any sense at all. Yeah. I mean, and I think that I think what I love about, sort of work that you're doing, obviously the impact on, those with allergies. But I think it's such a good example of sort of these simple, low tech, easy remedies, treatments, preventative measures that we continue to kind of ignore because the system is built, to ignore them. And not because, I also stand by the fact that everyone who works in healthcare, even the insurers, pharma, goes into healthcare because they want to help people. They want to help people be healthy. There's no one who says, I want to stop people from being healthy. It's just that the laws, the policies, the real systemic issues within healthcare tend to push whatever stakeholder they are to make poor decisions that tie their hands in some way. And ultimately, to make any change happen, we have to do what you're doing, which is to take, sort of these small examples that are, have impact, but make huge change, right? And to really go after, this. So I think your story is super inspiring from that standpoint. Tell our audience a little bit about, what that has been like. I mean, in terms of sort of changing the conversation, both, we talked a little bit about insurance. I imagine you also talk to a lot of pediatricians and parents and kind of get the word out that way as well. I mean, it's obviously available to folks otherwise as well.
Yeah, it's so look, overall, everyone wants healthier children, right? And then healthier humans. Like they're just, I don't know who you are that would not be the case, right? So, so in general, it's a really easy conversation. It's been really gratifying. It's great to see. A big study came out that CHOP did, Children's Hospital of Philadelphia, where they showed that peanut allergy rates are falling in the United States as pediatricians implement and talk to more parents about early allergen introduction. They estimated 66,000 children who would have had a peanut allergy don't have one today because of that. So it's great, right? Like that's a healthier population. We can get a win. The other side of it has just been sort of fascinating, like study of human psychology, of like how people just don't evaluate things on the basis of the data. They just want to see other people do it. Like most people are not actually evaluating whether something is true or false. They're just evaluating if other people are doing it. And like that kind of thing. And also, but even amongst a lot of doctors, like you get pushback. They're like, well, people don't need products. And I said, okay, do you use baby food? And they're like, yeah, all my patients use baby food. I was like, baby food isn't a real thing. It's just adult food that's been pureed. Like, there's no reason for the baby food aisle to exist. It's like, well, you needed a company to mash a banana for you and put it into a pouch? Like, that doesn't make any sense. But I can tell you as a parent, I did actually need that. There were a lot of times I didn't have the time. And yes, I needed the baby food. So, but how can a doctor like wrap their head around? And I actually got into a debate once with a doctor. He said, well, people don't need products. They can do early introduction themselves. And I said, oh, okay. So what are you having for dinner today? He said, takeout. I was like, all right, so tell me more about that. So you can't feed yourself, but you're sure that your families can, and you're hungry, you have a problem and you're willing to feed yourself, but like, this is a problem they don't have. So anyway, that has been really fascinating. I think, just that like this whole idea of food, like we really in the United States have separated medicine from food. Right. And yet we intellectually understand that it is our medicine. And yet, but like bridging those two things has been shockingly challenging.
It is. It's systemic. I mean, and then at the same time, you've got, FDA, right? So the Food and Drug Administration, we actually deliberately, we by doing that have to some degree made that distinction, and it continues to be. And I think, we talked about this a little bit earlier around what is that distinction, that drugs have an inherent risk, or there's a cost, a risk benefit calculation. That with food, for whatever reason, we don't attribute that to. But of course, some of the foods that we eat are some of the more risky things we put in our bodies.
Yeah, but this is true also, right? Like, so people believe that their drugs are cleaner than the food they eat, right? Most people believe, oh, the drug is made at GMP, it's higher quality. But I can tell you from having worked in both scenarios, I was like, look, I always remind people, I was like, how big is that Tylenol you took? How much? And then think about the bacterial load that it could get away with versus the salad you just had. Right? Which of those two things is bigger? So which one do you think is cleaner, actually? The salad is actually cleaner. Our food is actually often produced at higher quality with less bacterial load than our drugs are, because you're not taking enough of anything to get sick off of it, right? And you brought up this point about why did the FDA start approving drugs? It's because we thought they were risky, right? The thalidomide scare showed us that you can't just put anything in humans and assume it'll be fine, right? That it's not a scare, the thalidomide disaster, I should say. There were certain things that could have value, but we needed to prove that they had value because they were so risky. But we don't approve food because it's not risky. It's not dangerous to eat kale. It's not dangerous. I mean, when it's produced at the quality that American food is produced at, it is not inherently dangerous. You can't like OD, on spinach. So there's no risk, right? So that's why the FDA doesn't have to step in, because you will naturally stop eating it. You will be fine. And so, but it's somehow that got inverted where people thought, oh, the fact that they're approving it means that it's better for me. But it's actually the opposite. The fact that they're not approving the food is what makes it better for you. The fact that it was never risky to begin with. It has all these upsides.
We can talk about it. We can talk about kale and bananas and real foods, but 99% of us are eating foods that are so full of chemicals and, drugs and additives and everything else that, there's that the idea that we don't then continue that we've not put together the fact that food is medicine is, makes very little sense. And I think, you see it, there's certain things, obviously Europe and internationally where they do not, you can't have a Twinkie. Mm-hmm. There's all because the additives and the chemicals that are in there, that it's become food is poison, and half of the stuff that we're eating. Right.
They take a rational approach, which they just say individual ingredients pose a risk or don't pose risk, and then need approval or don't need approval before they get into the system. Right. So that the plastics in your chewing gum, they might say, well, hey, nobody needs that, right? And it is a potentially risky thing, so let's make sure it's safe first. Whereas we're not going to do that with the banana, right? And we weirdly are like, if you're eating a lot of it, that's fine. But if you're going to put a little bit in your Tylenol, and then we're going to ask a lot of questions.
Right. Yeah, no, it is, and it just goes back to the system, the system, there's a lot of levers to change. And so yes. I really, it's, I think that there's, the work that you're doing to kind of, impact and make change around the policy. Tell our audience a little bit what they can do. Can they help in terms of, particularly in New York and Pennsylvania? We've got lots of listeners there.
Yeah. I mean, the number one thing anyone in Pennsylvania or New York can do is call their state representatives or assembly members in New York and senators and say, hey, I know this bill. It's House Bill 674 and Senate Bill 978 in Pennsylvania and Assembly Bill 771 in New York. And I forget the number of the Senate bill. But in any case, the insurers won't let them come up for a vote. And all you can ask is like, I'm not asking the senators or representatives. I'm just saying, let it come up for a vote. If this is something you care about, you think it should be heard, right? Like, let the debate at least happen.
Yeah. And then in terms of,
works.
Yeah, right. Call and make noise. That's how we can make change and make an impact. In terms of folks who might be, have kids and who are interested in, getting Lil Mixins, can they get it themselves? They have to go through their physician. What's the best way to get it?
No, Lil Mixins is totally available, D2C through Amazon or anything else. And I do want to caveat the two things like that I've been pushing back on. Number one, that you don't need Lil Mixins. If you are comfortable making the foods and preparing them safely for your kid, please, by all means, go for it. And in fact, we restrict our customers on our subscription to 4 months because after that, your kid should be old enough to be eating real food. So we don't want people on, even the dehydrated forms. They're perfectly the same nutrition.
I can't.
But my point is
supplement my protein needs that I hear so often.
That will make sense. Please just eat the naturalist version, right? Like if that's peanuts or if that's peanut butter. We really want babies, especially, eating as close to exactly what they're going to eat as adults, and so that's great when you can do that. So you can get it at online, all the major sort of places, but also feel very, very free to make it yourself and do that, because I think a whole food diet is the best medicine we have.
Absolutely. Well, with that, thank you so much for joining us. It's really just been a pleasure to hear the story, learn about the work that you're doing, and think about it in the context of, kind of this bigger picture around, making an impact, food as medicine and food is medicine, and making those changes so that prevention, is just easier for folks, because that's really what it all comes down to in terms of health. So thanks for joining us. Thanks you to our audience, and thank you for joining us on Digital Health Talks. This is Megan Antonelli, and we'll see you next time.